Well, hello, everybody. My name is Arwen McDaniel, and I'm the Academic Fieldwork Coordinator at University of Arkansas Cott's OTA program. And we have prepared your Fieldwork Educator Training for spring of 2025. So we're going to get started. We're going to be discussing Choosing Wisely and the AOTA Vision of 2030. All right. So Choosing Wisely is an initiative that was designed by AOTA and published by AOTA to discuss the 10 best practice recommendations as part of the Choosing Wisely campaign. It's aimed to promote meaningful conversations between practitioners and clients and to ensure quality healthcare that is cost-effective and proper for our client-focused care. Choosing Wisely was a partnership between the American Board of Medicine Foundation and specialty societies and was active in generating clinical recommendations from 2012 through 2023. Going forward, the ABIM Foundation is moving their focus away from developing and maintaining recommendations through Choosing Wisely. However, AOTA will be maintaining and annually reviewing and updating Choosing Wisely as needed. Okay. So, Choosing Wisely, number 1. Don't provide intervention activities that are non-purposeful. Cones, pegs, shoulder arcs, arm bikes, okay? We want to use purposeful activities. These are tasks that are part of daily routines. They hold meaning for our clients. They are relevant to their everyday life, and they have perceived utility, such as personal care, home management, schoolwork, ADLs, IDLs, etc. Okay. Research shows that using purposeful activity or purposeful occupation in interventions is an intrinsic motivator for patients. These activities can increase attention, endurance, motor performance, pain tolerance, and engagement. It's resulting in better patient outcomes, which is what we all want, okay? Purposeful activities they're building blocks to a person's ability to achieve their goals. Conversely, non-purposeful activities do not stimulate interest or motivation, and that results in reduced patient participation and suboptimal outcomes. So how can you begin to involve more purposeful activities in your practice? A couple ways that are suggested by AOTA is to host an occupation drive. Make a wish list of items that you need, share it with your staff and the staff throughout the facility. Ask them to donate their unused household items such as kitchen, housekeeping, craft supplies, anything that can help somebody perform through the domains and processes of the OTPF at a functional level. Another idea is to hold a monthly OT challenge. So to start incorporating more occupation into practice, choose a month to focus on purposeful activity. Each week of the month, challenge your colleagues to replace a non-purposeful intervention with an occupation-based activity. So for like week 1, no arm bike, they have to put function in place of it. Week 2, no shoulder arc, put function in place of it, okay? So if your client's goal is to increase standing balance, standing and dynamic for participation in IADLs, and their strengths are they can stand with contact guard assist for 5 minutes before resting, can walk with minimum assistance with a front wheel walker or a hemi walker or cane. Their barriers to the goal is that they lose balance in any direction based on diagnosis. You can try obtaining items from kitchen to prepare a simple meal, gardening, planting, watering, weeding, putting dishes away, retrieving bird feeders and refilling feed, instead of performing ball toss, balloon toss, playing cards, or puzzles. To facilitate success while providing the Just Right challenge with supports as needed. So you may assist the client to identify personal signs of fatigue or activities that trigger loss of balance, such as a distraction from someone speaking to the client. We want to make sure we incorporate appropriate techniques for management. So next up, we're going to be discussing sensory-based interventions, okay? So number 2, don't provide sensory-based interventions to individual children or youth without documented assessment results of difficulties processing or integrating sensory information. Many kids and youth are affected by challenges in processing and integration of sensation, okay? So processing and integrating sensations are complex. They result in individualized patterns of dysfunction that must be addressed in a personalized way. Interventions that do not target the documented patterns or dysfunction can produce ineffective or negative results. It is imperative to assess and document specific sensory difficulties before providing sensory-based intervention. Those interventions could include air sensory integration, weighted vests, listening programs, or sensory diets. So it's important to do those assessments first and get them documented. Make sure that you know officially you are addressing sensory concerns. Some sensory integration, sensory processing specific assessment tools are items such as the evaluation and air sensory integration, the sensory profile 2, some related assessment tools to look at specific sensory systems, motor skills, self-care, etc. Could be the Beery VMI-6, the Brief 2, the DTVP3, the MVPT4, the PDMS3, the PDCAT, and the TOP, which is the test for playfulness. So when you're trying to make decisions regarding sensory evaluation, AOTA has created a chart, okay? So the concerns have been raised. They're having some difficulties, okay? So you're gathering some information, okay? You've identified some sensory differences, and then so you can implement sensory-based intervention, okay? So we come down here, we have identified issues, now we can bring in sensory, okay? If we don't have data to support sensory processing or sensory integration concerns, okay, then we need to look at the underlying causes of occupational performance difficulties within the scope of the OT practice, okay? We can provide intervention based on evaluation results, okay? And then the other option is underlying causes of occupational performance difficulties not in OT scope of practice. So we would refer to the appropriate professional depending on what our client needs there. All right, number 3, don't use PAMs without providing purposeful and occupation-based intervention activities, okay? So, excuse me. PAMs need to be provided with functional component because it can lead to more positive health outcomes. PAM should be integrated into a broader occupational therapy program and intervention plan in preparation for or concurrently with purposeful activities or interventions that ultimately enhance occupation. Okay. So this is a quick check sheet for you to be able to utilize to know if you truly need to be using a PAMS, okay? So areas to be addressed. All right, we're looking at pain, protective sensation, edema, and wound care. This is sensory functions, right? Along with pain and wound care. Then you have the neuromuscular areas and movement. PAMs that would coordinate with that area, those areas of need, and then any other modalities that and assistive technologies that you'd like to include that you can document on. So it's just a little guide to help you do that. So when you're working with PAMs, if your client's goal is to return to completing housekeeping tasks after a recent fall, and their strengths are independent for indoor mobility, has within functional limits of strength in proximal upper extremity and can reach above shoulder level, and their barriers to their goals include pain and stiffness in the hand with difficulty grasping objects. They're fearful of falls due to past medical history of vertigo. You can try preparatory paraffin for hand with Coban wrapping inflection, washing, drying, and folding laundry, hanging clothes in a closet, making a snack or cup of coffee, brushing teeth after opening toothpaste, instead of performing therapy putty exercises, a hand exerciser, or tabletop activities. To facilitate success while providing the just right challenge with supports as needed, you can use a gait belt for balance, verbal cues providing physical assistance if anxiety is noted regarding to onset of vertigo event with reaching and bending tasks. So those are some ways you can get creative with PAMS. Number 4, don't use pulleys for individuals with a hemiplegic shoulder, okay? There are multiple reasons for this, but it's considered too aggressive and it should absolutely be avoided. A patient can cause more damage to their hemiplegic shoulder when using pulleys. So we want to use gentler and controlled range of motion exercises and activities that are preferred. Now, when we're working with the shoulder, where do we always start? The scapula. Okay, so always make sure you're checking the scapula. Is it moving the way it is supposed to do? Okay. Make sure that those scapular mobilizations, that you're able to feel the scapulohumeral glide before beginning mobilization of the upper extremity, okay? Another thing that is great to do here is incorporate the affected extremity into functional activities. This would take the place of a pulley. So after initiating your preparatory range of motion techniques, the affected upper extremity should be incorporated into occupation-based functional activities, okay? So strategies for incorporating the affected upper extremity activity should be graded according to functional process or progress. Excuse me. Okay. So here are some safe and effective intervention strategies for hemiplegic shoulder patients. Okay. So supportive surface with a towel, doing glides to help them be able to reach for a can, a cup, something that they would be using on a daily basis to make it functional. Use the affected arm to support the, use the unaffected arm to support the affected arm while performing self range of motion, because we want them moving their arm, right? We can't just do it ourselves. They have to be able to do this on their own. We can also incorporate weight bearing. And we can grade the activity with direct support monitoring depending on what they need, but we need to go ahead and get weight through that area. All right, moving on. Number 5, don't provide cognitive-based intervention without direct application to occupational performance. This is paper pencil tasks, tabletop tasks, software for cognition, okay? We need to embed cognitive-based interventions into occupation relevant occupations that are relevant to our patients. Okay, so some examples of cognitive-based interventions include awareness approaches, strategy training, task training, environmental modifications, and assistive technologies. So there are 4 elements to include in a functional cognition toolkit. They are practical community access materials. Think about maps for the facility they live in, the town they live in, maybe the school district or the city they live in. They need information on support groups, okay, and community centers, and schedules for the facility or their local community activities, their senior centers, areas they like to be involved in. Okay. The second area to include in a functional cognition toolkit is the kitchen and household. Okay. Cookbooks, cooking utensils, cleaning supplies, food items, timers. These are all things that can help someone perform cooking tasks and other IADL tasks within the kitchen setting. 3, supplies for personal organization and work. Okay. We all use some kind of planner or calendar. Our patients need to as well. Templates for lists, templates for planning, office supplies, pens, pencils, sticky notes, however they need that. whiteboards, dry erase boards, chalkboards, whatever that client likes and is their preference. Those can be incorporated into cognitive-based interventions. And again, it's client-centered. It is functional occupation. The fourth area is handbooks. Okay, and this is for assessing useful computer programs, apps, websites. So we're talking handbooks for tech, basically. So maybe transit schedules and ride sharing apps. Okay, how can they access that? You may have to type up in a document how to access those items on the phone. Online menus and meal planning resources. Again, we can do this online, and this may be beneficial to your client. Budgeting and money management tools, and then also instructions for their smartphone. Maybe there's instructions for the smartphone calendar, the alarm, and app management, how to maintain all of that. Okay. So if your client's goal is to return to work following a mild TBI, and their strengths are no impairments in mobility or range of motion, the client identifies work as satisfying and important, and they have a supportive employer. Their barriers to their goal are impairments in short-term memory, selective attention, and sustained attention, limited activity tolerance. You can try an intervention in which the client performs simulated work tasks incorporating planning, prioritization, and time management skills. OT and the client identify necessary workplace accommodations instead of completing paper and pencil worksheets, board games, or other tabletop games, and instead of using cognitive training software. Facilitating success while providing the just right challenge with supports as needed. So you can grade the difficulty of the activity, such as by number, complexity of the task, maybe the session length. Graded cueing, graded environments such as noise and activity level in the space. Act as a liaison between the client and the employer as needed. Okay. Moving on to number 6. All right. Don't initiate occupational therapy interventions without completion of the client's occupational profile and setting collaborative goals. For truly focused client-centered care, we must communicate. We must know what the client wants. Creating an occupational profile and setting collaborative goals are key strategies to ensure occupational therapy services are client-centered. Okay? The OTPF states that only clients can identify the occupations that give meaning to their lives and select the goals and priorities that are important to them. By including them and being collaborative, we are demonstrating respect for our clients, demonstrating the distinct value of OT, and we can provide higher quality services that are more meaningful to the client. So when you're meeting with them, ask open-ended questions. Incorporate the client's care partners as needed, okay? Discuss goals, context, barriers, supports, informally, casually with the client. It can be a casual conversation and glean lots of important information. You also need to be able to advocate for including the occupational therapy profile in your facility's electronic health record. You may find something out through your open-ended questions that no one else has found out, and it might be important to the entire care team. So they need to be able to see your occupational profile. And you can build this occupational profile by using the AOTA occupational profile template as well. It doesn't have to be a narrative typed up paragraph. The form that they've created can help OT practitioners smoothly gather all the information that they need for an occupational profile. All right. Number 7, okay? Don't provide interventions for autistic persons to reduce or eliminate restricted and repetitive patterns of behaviors, activities, or interests without evaluating and understanding the meaning of the behavior to the person, as well as personal and environmental factors, okay? These patterns of behavior may serve as meaningful activities for self-regulation, communication, or self-expression. Attempting to change, or extinguish these behaviors without direct requests from the individual, without understanding and incorporating the underlying meanings, or substituting other actions to meet self-regulatory reasons for the behavior commonly results in camouflaging or masking or hiding of these behaviors that can result in a negative self-image, depression, and an increased risk of suicide. So be very aware of what you're working on and what that pattern is. And is it appropriate for that patient? Is it helping them self-regulate? Is it helping them in the stage they are now? So this is a grid from Choosing Wisely about repetitive action. And if they are identified as a concern, who is concerned? Is it someone other than the individual, or is it the autistic individual? If it's the autistic individual, we should provide support. We should help them find a way to stop or change the repetitive action because this is their desire. This is their goal. Now, if who is concerned is anyone other than the autistic individual, family, therapist, doctor, okay, is there an immediate threat to safety? If yes, there needs to be further evaluation and intervention potentially taken, okay? If no, has there been a change in frequency, duration, intensity of these repetitive actions? No, intervention to stop or change the action should not be provided. If we don't have an exacerbation and it's what they normally do that is typical for them, there is no action that needs to be taken. However, if it's yes, further evaluation may be needed. Changes in repetitive actions may indicate something positive or negative going on in that individual's life that needs to potentially be addressed. Okay. All right. Number 8. Don't use reflex integration programs for individuals with delayed primary motor reflexes without clear links to occupational outcomes. All right, so interventions designed solely to integrate retained reflexes do not promote participation in occupation. And while they may be observed in clients with difficulties in occupational performance, the presence of retained reflexes does not necessarily equate to functional impairment. If reflex integration techniques are being considered for intervention, standardized tools and assessment approaches are necessary to connect impairment to occupational performance. Intervention should focus on improving occupational participation and performance rather than solely on reflex integration. So finding a way to perform the occupational task that needs to be completed without necessarily trying to integrate a reflex. Don't use slings for individuals with a hemiplegic arm that place the arm in a flexor pattern for extended periods of time. So when you put the hemiplegic arm in a flexor pattern and you're in this position for an extended period of time, it increases the risk of contracture and pain. It also limits the active use of the extremity. And that then decreases opportunities for neuroplasticity and for changes to occur in the brain that support an organic increase in function. Education should be provided to the clients and their families and caregivers on safe positioning of the hemiplegic arm during activity and at rest. So let their arm be quote unquote free. They need to be taught to monitor where their arm is located because they may not have feeling on that side. We want to make sure that that limb is safe, but we also want them, if they can, if they're using it if they can use it a little bit, they could use their opposite hand to help them move that arm to help co-grasp a cup and do some bilateral work and so forth. So we want them to be aware of that arm. We want them to keep that arm safe, but placing that affected limb in a sling can cause sometimes more concerns than it can help. All right, number 10, don't provide ambulation or gait training interventions that do not directly link to functional mobility. Okay. Gait training and ambulation are words that are not meaningful to a client. Okay. We want functional mobility to be personally meaningful to the client. They're going to and from a task, maybe from the bed to the toilet. Okay. Or maybe they're carrying an object. Maybe they're carrying a grilled cheese sandwich from the kitchen stove to the table for their grandkid. Okay, so those are the types of things that are truly meaningful to the client. Now, when we're working with the client, we hear them say, for a goal, I want to walk again. It's a great place to start. Great place to start, okay? Ask questions to understand why the client has this goal. Depending on where they're living, ask where they would like to go in their room, the home, the community. What would they like to do? Okay, where can they be mobile to get to do the task they want to accomplish? Okay. So another aspect of functional mobility is transfers. So we need to discuss the ability to transfer using a tub transfer bench, a slide board, being able to safely access their bathroom or kitchen. Okay, so functional mobility is meaningful. Okay, tie it in with occupation. All right, Vision 2020 or 2030. All right, this has recently been announced, and the vision statement is enriching life for all individuals in society through meaningful engagement in everyday activities. You can see the 4 foundational pillars that address inclusivity and equability of professional community, evidence-based, client-centered, and innovative practice, and then universally recognized with valued excellence, and then occupational justice and advocacy. So how does this all tie in together? All right, so Choosing Wisely and AOTA Vision 2030 are interconnected. Inclusive and equitable professional community is the first of the foundational pillars of the vision and is supportive of all OT practitioners to belong, collaborate, network, and foster growth and development amongst each other. As we all follow the tenets of Choosing Wisely, we will be able to help each other grow in client-centered care. We can share ideas and insights to increase patient outcomes. Pillar 2 is asking us to deliver high-quality skilled care using evidence-based, client-centered, and innovative practice. While focusing on individual client needs and collaborating on goals as stated within Choosing Wisely, we will be able to use innovative approaches and once again increase patient outcomes. By integrating Choosing Wisely into Pillar 3 of the vision, which is OT being universally recognized with valued excellence, occupational therapy practitioners can establish the importance of OT across various settings and demonstrates our uniqueness, our inherent value in improving a client's quality of life and functional abilities. We can utilize a top-down approach, building in functional activities and occupation to solidify our standing in the therapy world. Occupational justice and advocacy, accessibility, and the right for all persons to engage in the occupations of their choice is Pillar 4 and ties in with Choosing Wisely beautifully. This is by putting client-centered care first and foremost, following best practice for each client, and doing it in unique ways to fit them. Both Choosing Wisely and AOTA Vision 2030 are inextricably linked to the heart of occupational therapy practice, education, and research. Both are essential to the profession's ongoing viability, success, and vitality. And here are references. Thank you all for watching this video, and if you have any questions, you are always welcome to reach